Good evening to all. I'm from Cancer Institute. I'm a surgical oncologist. The first topic is frequency and outcomes of new suspicious lesions on breast MRI in the setting of neoadjuvant therapy. This is from Department of Radiology and Biomedical Imaging, University of California, published in AJR in March 2021. Now, we all know the benefits of neoadjuvant systemic chemotherapy, and response assessment is an integral part of the treatment. Now, MRI is the most sensitive of the modalities available, but it lacks specificity. Now, this study was a retrospective data review done between 2010 to 2018 on a total of 419 MRIs done in 297 patients. After exclusions, they included only the patients who had new lesions which were confirmed to be BIRADS4. So it was a total of 23 patients which were identified for the study. A bulk of them were premenopausal, and 56 of the new lesions were contralateral. The MRIs were done with a mean of 3 months from the start of therapy. 83% of the tumors, primary tumors, showed response to treatment. The changes in the new findings were presence of a mass in 70% and non-mass enhancement in about 20%. This is one such patient whose MRI showed a new lesion in the contralateral breast. Now, all these patients, biopsy was done in 8 of them, either by MRI or by ultrasound. All the biopsies were benign. In 7 patients on whom the lesions were kept on follow-up, stability was confirmed at 2 years by a repeat mammogram, and in selected cases with a repeat MRI. It confirmed stability, meaning they were all assumed to be benign. In 8 patients, surgical excision was done. 7 of them, it was a mastectomy. None of them showed malignancy in the region of interest, and 1 of them had an excisional biopsy that was also benign. So in conclusion, the authors like to conclude that on patients on neoadjuvant therapy with response to treatment, appearance of new BIRADS4 lesions on the MRI is most likely to be benign and biopsies may not be required. However, they recommend larger prospective studies for the same. Their limitation, as acknowledged, is that it's a retrospective single institution study. They did not reinterpret or remeasure the MRI findings. The benign nature correlating to the new lesions were not specifically confirmed by the pathologist. And they excluded, they say, BIRAD6 lesion, but one of these patients had a BIRAD6 lesion, but it was included in the analysis because the new lesion was contralateral. My opinion on this is, it is not clear whether they contemplated BCS for any of these patients. The initial stage of the patients is not known. The treatment regimens were varied, ranging from chemotherapy to CDK inhibitors. So I'm not sure whether some of them were actually M1 disease. BIRADS4 lesions also has not been subcategorized into A, B, and C. And I would have thought that a better correlation with pathology and a reinterpretation of the MRI images would have helped. I personally think that in patients on neoadjuvant therapy with clinical response, why should we often do interim imaging if clinical response is already there? Personally, in our institute, we rarely perform repeat imaging if the clinical response is present. My next paper, of which I'm also a co-author, is on locally advanced breast cancer. It is a real-world outcome of patients from Cancer Institute, Chennai. These are the other co-authors, all work in the Department of Breast Oncology. This was published in May 2021. The key objectives was to look at the prognostic factors of patients with locally advanced breast cancers and to see the impact of concurrent chemoradiation. Now, the total cohort of patients studied were 2,137 patients. 71% of these were grade 3. Operable LABC constituted 30%, whereas the inoperable LABC was 70%. Hormone receptor was positive in 65%. HER2 was positive in 25%, that is 3 plus. In 19%, the HER2 was a 2 plus, but we couldn't do a FISH. We didn't have the facility at that time, so none of them had a FISH. Of the treatments received, 77% received concurrent chemoradiation, 15% received concurrent chemotherapy, and a mastectomy was done in 99% of the patients. Trastuzumab was given only in 0.5% of the patients. All patients received, hormone-positive patients received endocrine therapy, and 97% of the patients also had irradiation who didn't have it earlier. Now, this is the slide that shows you the choice of neoadjuvant chemotherapy or chemoradiation was entirely left to the discretion of the surgeon who evaluated and treated the case. So a bulk of the inoperable patients went into the concurrent chemoradiation arm. This slide shows you the incidence of pathological complete response in those receiving concurrent chemoradiation, which is close to 25%, whereas only with chemotherapy, it was 18%. As expected, the hormone-positive patients had a low PCR at 15%. The HER2 positive had it 18%, and triple negative had an impressive 41%. This is the slide showing the survival of the entire cohort. Both the OS and the DFS are displayed. At 5 and 10 years, both of them are clear just above 50%. This slide is to show a particular group of patients whose size of tumor is more than 10 centimeter. They have fared distinctly worse than the other two groups. The follow-up at the institute is quite impressive. Only about 2.3% are totally lost to follow-up. So in the follow-up, we detected second primaries in about 2% of the patients. The local regional failure rates were, the total patients who recurred are about 27. A bulk of them are distant, and local regional failures were only seen in 13% of patients. The author's conclusions: this sample is a large sample of locally advanced breast cancer from India. We found that tumors larger than 10 centimeter had an unfavorable outcome, and we propose whether they should be considered for inclusion to clinical T4. Patients with triple negative breast cancers had high PCR rates, both with neoadjuvant chemotherapy and concurrent chemoradiation. On multivariate analysis, we found that besides the usual factors as stage, hormonal status, treatment modality, PCR and lymphovascular invasion also significantly correlated with survival. And we await the results of a randomized trial comparing these two modalities from the institute. For discussion, I'd like to mention that all these patients did not have a CT chest or a PET CT. About half of them had either of these, but the remaining half did not have. Equivocal HER2 IHC could not have FISH testing because of resource constraint. Trastuzumab was given only in 3 patients of the entire group because of resource constraint. Presently, the situation is different. All non-metastatic patients receive trastuzumab. I personally felt that we could have given more data on the morbidities and tolerance of concurrent chemoradiation, which would have been more useful to other institutions to consider the use of neoadjuvant concurrent chemoradiation. And as I already said, an impressive follow-up of 2.3% only lost is a good thing. My take-home message is that we should consider concurrent chemoradiation as a feasible treatment option for inoperable locally advanced breast cancers. I strongly feel that clinical assessment of response is enough. Most of these patients, in fact, 99% of the patients whom we have put in this paper, none of them had repeat mammogram or MRI. I feel imaging should be restricted to patients with doubtful response or suspicion of other sites of progression. The ideal chemotherapy to be used in neoadjuvant with radiation is not clear. We have used adriamycin, we've used epirubicin, taxanes, and anthracycline, but we are really not sure which is the ideal modality to use. Thank you.